So my name's Suzanne MacArthur. My background, I'm an occupational therapist by profession, but left the NHS about 12 years ago and moved into the hospice sector, where I worked in Marie Curie for about 8 years, 8, 9 years, as a manager and in community engagement, and then moved to Birmingham Hospice as head of community development and partnerships, where I worked there for 2 years, working with the diverse communities of Birmingham, looking at how, as a hospice, we could engage better with those communities and meet their needs in a more culturally sensitive and appropriate way. So, having been a manager within the hospice setting, I was really, really clear. I could just see it that actually, as a hospice provider, palliative care service provider, we thought we're the expert, and that communities should fit in to our service. That we knew what the communities needed, and yeah, they should fit in. And it wasn't surprising that actually the majority of people that were accessing our services were white middle class. And the opportunity for me to go out and actually meet and consult with those communities about what good end of life care looked like for them and what good grief support looked like for them actually really opened my eyes, that actually we weren't doing it right at all. There was a totally different focus on what was important to that community that wasn't what we were delivering as palliative care providers. We were missing some real golden nuggets. So, our palliative care services were all focused on symptom control, looking at, obviously supporting that patient and their family through that journey, but in the way that we thought that they needed it. We've got our systems in place, people that we would refer them to based upon what we thought was best. And what I found was actually that's not what they wanted. There were things that weren't even on our radar.
My name's Colette Hawkins, and I'm an academic consultant in palliative medicine based in the northeast of England. And I worked as a clinical consultant in Durham for many years. I have an academic portfolio now, largely because I am very interested in gaps in how we deliver care in the NHS, and the needs that people have that we're possibly not meeting as we should be. So I've spoken to people who have been through in caring roles or cared for people that they've looked after, who have developed such a wisdom from their own experience and often quite hard experience where they've had to battle to get services and advocate for somebody that they're looking after against services who put up a lot of barriers. But because they've come through that, they have a tremendous amount of knowledge that they are desperate to share with other people because they know that's a difficult experience. And one of them even described the army of carers. There are thousands of us, she said. We've learned this through often quite difficult experience, and we've got this wealth of knowledge. We want that to be used. And speaking for myself, I think that I very much had a clinical focus. That was what I was comfortable with. And I really didn't understand the struggles that people had beyond the illness that I was treating. And I was quite naive, really, in terms of how much life is turned upside down by a serious illness and how many people that then impacts. I was not particularly in tune with the impact on people looking after the person who's ill. But in running Roots to Rights research, we've had quite a lot of conversations with members of the public, both people who are ill themselves and people who support other people who are ill. And it's really lifted the lid on how the breadth and the impact of some of these non-clinical issues that people face, that we just aren't engaging with in specialist palliative care circles. And that's certainly been my experience. communities offer something that palliative care services, by and large, are not offering, and to some extent, perhaps don't have the capacity to offer. And it makes no sense not to use knowledge and local wisdom that is there for the taking. And these are people who want to be sharing what they've learned. These are people who have the life experience that walking through that, it puts you in such a powerful position to support other people. It makes no sense not to capitalize on that. It's just missing a huge part of need. And if especially palliative care services don't offer that, there is a massive gap. So we have to, which communities are filling. If we're working independently of each other, it just doesn't join up.
Yeah, I'm Saif Mohammed, and I'm joining from Kerala, India, from Calicut, which is a northern city in Kerala. And I'm joining from Institute of Palliative Medicine, which is one of the WHO collaborating centers, and also the first palliative care institutions in the whole of Kerala, which was founded by the first palliative care society in Kerala, called as the Pain and Palliative Care Society in 1993. And I started off as a volunteer when I was in college. Then after that, I served as the state project manager for the government palliative care program, for which our institute, IPM, was the nodal center. Then now I'm working as the academic consultant at the Institute of Palliative Medicine, basically developing programs around community palliative care, bereavement, and things like that. But as doctors and nurses, they are busy, and they work within an institution. It can be an hospice or a hospital. So what they do is that they usually look at the medical component, their physical issues. But unless and until the other issues are not attended, I think you're not getting to the total care of the patient. But for that to happen, you will not be able to do it alone. And in Kerala, one thing that we have realized is that we were able to recognize palliative care more as a social issue with a medical component rather than a medical issue with a social component. And when you look at the problems faced by the patient, there are clinical issues, there are physical issues that you have to address to. But if you look at the wide range of other issues, it's not something a doctor and nurse can prescribe medicine for. It's something that the community has to come together, learn the skills, and support each other to address those issues. And when the clinical team and the community come together, what I've seen is that it can result in a lot of impact on the well-being of the patient and the family. One thing that I've noticed is that when the doctor or a nurse goes to the home or to the house of the patient, you'll get the real picture. So you may be prescribing medicine, you may be prescribing a lot of things there, but unless you understand the real picture of the patient and the family, sometimes it's futile. That you don't know whether the patient is going to have the medicine. You don't know whether the patient will be in our settings. That if the patient will be able to afford the medicine, and what are the other issues in that house, who are all there to support them. So all these things you'll not be able to see unless you go there and see it for yourself. And one thing that we do in IPM is that we tell people, it's a message that we pass on to the community, that this is an essential life skill. Caring for someone with a serious health-related suffering is a life skill, because this can happen at any house, any time. So it's like any other life skill, like learning driving, swimming. And then this is a continuous skill building program for the community that's happening at IPM. We have already trained around 6,000 people now, and there is a huge waiting list. And once they learn the skill, what we are giving them an opportunity to be a part of the care that is happening within their community. So what they become, in simple terms, what they become are they become the companions of the people who are already suffering.
My name is Kelly Stadjahar, and I'm a nurse. I'm a professor in the School of Nursing at the University of Victoria in Canada, and a Canada Research Chair in Palliative Care and Community Health. Oftentimes we talk about, we want to work with people, we want to work with patients first, but and I don't even like the word patient, but we don't ask people, what they need from us. And I work in communities of people who are not particularly well served by mainstream palliative care. And definitely what I found in my working community is that the way in which we have designed our services actually don't work very well for most of the people that I'm in contact every day in my work. And it makes it really tough when our services are not designed in ways that, will be helpful to all people. So I think in our clinical work and in our service development, we often think of this, I want to say, standard person that we see in palliative care, which is typically people who are white, middle, or upper class and have cancer. And, that's not the only people when you go into community, you see that there's a whole community of people that actually could really benefit from a palliative approach to care, but in ways that actually work for people. So, my working community informs everything that I do, from the research projects that I do, from the way in which I interact and relate with people, from the way that I try to advise government on service redesign, because not everybody that enters our palliative care services is a standard patient or standard person. I work with a lot of people who experience homelessness, or may be precariously housed. And, sometimes what will happen, for example, is, and what a lot of clinicians would not be aware of, is that oftentimes when people are in those situations and their health declines, they can no longer stay in a shelter or transitional housing because the staffing in those places are not they're not staffed with healthcare people, and they don't they're a little bit afraid of what happens when people decline because it's outside of the scope of their job description to help them. So what happens is somebody declines, 911 or emergency response is called, they're taken to hospital, and maybe whatever issue is happening is resolved and they are going back out and they find they no longer have housing. And so if you don't understand that, you're sending people back into environments where they're unlikely going to be able to stay, that the only way that you can know that is being in community and observing that firsthand. So like I absolutely know people who get evicted because their health is declining. And so in some ways I think, people say, well, that's a problem for the housing sector. No, it's actually a problem for us in palliative care, because if you think about palliative care as being care for the whole person, then we should be thinking about the social determinants of health, and that becomes our intervention in palliative care. There's a lot of people who, I always say in palliative care, we often talk about how, we have to manage people's pain before we can get anything else done. But like for the folks that I work with, pain is not their first priority. The clinical issues are not the first priority. The first priority for them is getting some food, getting some shelter, and getting some love, to be honest. It has completely shifted my whole way of thinking about how to care for people as a nurse. And I think I told you that story before, that I began my nursing career in the middle of the AIDS epidemic, and that's the work I was doing. And you know, at that time in the 1980s, I mean, healthcare people didn't want to care for people with AIDS, so communities had to look after themselves. And you know, when you watch that happen and you're embedded in that, you learn very quickly how to step aside when you're not needed. And I think probably the biggest learning for me was how do I put my own ego and need to help like to the side? Like that experience really caused me to reflect pretty deeply on like whose needs am I serving? Because I think sometimes in palliative care, we can get into this kind of situation where we think we're the only people who can do this. And I don't think that's the case at all.
Yeah, thanks for chatting with me. My name is Nahid Dasani, and I'm a palliative care physician who spends a lot of time providing healthcare for people who experience structural vulnerabilities like poverty and homelessness. I'm the founder and lead of Canada's first and now largest mobile palliative care program for people experiencing homelessness, the Peach program. I'm the medical director of Toronto's largest hospice, Kensington Hospice, and I work as a palliative care physician at an inner city hospital, St. Michael's Hospital, where I serve as a clinician, educator, and as a researcher as well. I think that in truth, um, when serving people who live in the community, particularly doing outreach, working in respite shelters and drop-ins, the approach to care often really has to be different because the focus of the issues that we see for people who, for example, experience precarious housing aren't always necessarily medical issues, or if they are medical issues, they're the result of indirectly the result of other issues upstream, like not having housing, not having food, not having money, or not having the social supports to get to medical appointments. And so when I work in the community, when I'm doing Peach outreach visits, when I'm supporting people and transitioning them, for example, to our hospice program, which is a program called Radical Love, which is an equity-oriented hospice palliative care program, there's a lot of attention paid to the social determinants of health, the kinds of social factors that people may or may not have, and also an attention to the structural determinants of health, which often are the determinants of the social determinants of health and inequities in them. Things like colonialism, things like racism, things like discrimination and oppression and classism, or even ableism, for example. A real analysis of those issues allows me to meet people where they're at in really unique and important ways. And I don't think I'd be able to care for people in the ways that they really need if I wasn't able to pay attention to them. The real way that we've had success in supporting people to be able to interact with the health system, enter into a hospital space, for example, if they need it, is to actually take our agenda, what we think is best, and throw it out the window. Sometimes, too often in healthcare, we think we know best, and we're well intentioned. Don't get me wrong. I'm not saying anyone's being bad or trying to do bad things, but sometimes we think we know best, and we don't really understand the circumstances and experiences of the people we care for. And in truth, this is what we really mean when we're talking about meeting people where they're at. It's about taking that agenda, taking what we think is best, and really throwing it out the window. I mean, I have a colleague, Dr. Maury, who works on our Peach team, and he always talks about how that initial visit should be less about filling out a checklist or completing our palliative care consultation template and making sure all the boxes are filled appropriately. Actually, the goal of that first initial visit for equity deserving populations should really be that we get to a place where they invite us back. And if they invite us back, then we've succeeded. And that means we might have met them where they're at. We might have overcome some of the trauma that they've experienced, and we might have actually succeeded in delivering person-centered, trauma-informed care. As medical director of Toronto's largest hospice, Kensington Hospice, which is a 19-bed hospice in the inner city of downtown Toronto, we've extended that peach philosophy. We call it that radical love philosophy, and we've created a program called Radical Love. What is Radical Love? Radical Love is a suite of interventions that we've implemented at the hospice level to really prioritize equity and justice-based hospice palliative care. We've redesigned our data collection processes. We redesigned the way we triage referrals, the way we assess need, for example. We've enhanced education and training for clinicians within the hospice that focus on things like cultural safety or trauma-informed care and harm reduction, for example. And we've implemented new roles like having health navigators and peer workers working within the hospice. The outcomes in just 2 years have been tremendous. We went from a hospice that cared for structurally vulnerable people less than 2% of the time to now a hospice that cares for structurally vulnerable people around 40 to 50% of the time. And that is a phenomenal jump that we've seen. And there's been an acceptance and a support among staff and a culture change, really. And so we're firm believers that radical love is something that doesn't need to just sit at Kensington Hospice in downtown Toronto, but this philosophy, this approach, this radical love palliative care approach can be applicable to any region, any community, and in any country to inspire equity-oriented hospice palliative care.